Could we have the red card and the green card again, please? This is a healthy audience. I can tell because listen to the coughing that's going on at the moment. This is a healthy audience. I'd like to know how many of you, only the green card if it's yes at the moment, okay? How many of you visited a pharmacist at least once this year, okay? Please put up if you once this year. How many of you, this is a healthy audience. How many of you visited a pharmacist within 6 months of this meeting? How many of you visited a pharmacy within 1 month of this meeting? Yeah. How many of you visited a pharmacist within a week of this? That is the indication to you of just how much a resource the pharmacists actually are. And this is a healthy audience, he said, coughing. Now, my point is this, I have to say to both of you on this, and then I'm going to open it up for discussion on here, because I know both of you are frank, and you do take part in this kind of discussion, and I have asked you, and you've said yes. But there is one individual in this room who actually has got a very deep interest in the retirement age, and that's Steve Borman, who sat at the back. The man who wrote the report on absenteeism, the man who worked with Carol Black, the man who incidentally turned around a loss-making part of Royal Mail into a profit-making, and then, of course, it was privatised once, of course, it was then profit-making. But that's besides the point. Now, this man is interested because you are lifting the retirement age, and yet you have made no provision to accept the fact that with lifting the retirement age, you will encompass more people who will suffer from long-term medical conditions and yet will have to remain at work, particularly low-income group people. Can you tell me what your provisions are to make sure that you are not rising the retirement age absolutely with futility unless you actually implement some kind of support structure to make sure these people with these long-term medical conditions can remain at work? We'll start off with the present government. Please.
Does that work? Yes, it does. This is absolutely crucial because the health of people at work is not only something that those people need to be assured of, it's what their employers need to be assured of. And there is a mutual interest in employers taking on this agenda, which is why, in conjunction with Dame Carol Black, whose work I admire enormously, and she's been working for not only us, but the previous government as well in this area, that's why we are jointly leading a work stream in the department comprising numerous partners from industry to engage industry and commerce in the health at work agenda. And this is part of what we've called the responsibility deal. It is already producing tangible results. Employers signing up to various pledges aimed at various aspects of employee health and well-being. And unless this isn't something you can legislate on. You can't pass a law in Parliament to oblige companies to do this. You've got to take them with you and to show that it's in their interests to keep their workforce well, both mentally and physically. Mental health in the workplace is very important. So we're looking at things like, the obvious things like chronic long-term health conditions, obvious things like depression and mental health, but also things you might not otherwise think of, like domestic violence. How do you make sure that people who are suffering domestic violence seek the help they need and are not absentees from work? So I'm very excited by this work. Dame Carol is a champion of it. We're engaging as much of the NHS as we can in this, in terms of the NHS as an employer. And bear in mind they employ an awful lot of people. We're trying to engage government departments and the public sector generally in all of this. So it's absolutely key. And I hope that whoever wins the next election in May will take that work forward, because it's vital.
And on that note of whoever wins the next election, the opposition.
Hi, I think that it's a very interesting question. Where I think the original work, research that actually led then to the health and well-being development, principally in DWP, but with the support of the Department of Health, was based on the evidence that working longer was generally good for people's health, provided it was healthy working. And I think you raise a very interesting point, that some aspects of work could not be called healthy working. And as people get older, they can be more difficult for them to undertake. So I'm very supportive of efforts to actually engage with employers in helping them have much stronger occupational health and health and well-being policies. And Freddie just mentioned the NHS. I must say that if I think about in every locality, if you look at the Health and Wellbeing Board and you look at the number of people employed represented around that table, principally local government and health, you're usually looking at the two biggest employers in any health and social care economy. And yet, I think to be fair, we would have to say that both local government and the health service do not have absolutely brilliant, consistent, outstanding policies in relation to occupational health and health, work and well-being. And I do wonder, in terms of going forward in the future, whether it would not be a very good idea to start, if you like, with the two areas where, in one way or another, probably government has more influence, and where this agenda should be so important. I've just retired from chairing a foundation trust in Birmingham, and as you'd expect, I tried to give this a push. But one of the issues I found is actually a lack of capacity in terms of people available in occupational health to come and help us. And I think that probably one of the things that government could do is actually look at the ways in which we can attract more people into the field. And I think one of the problems is that it goes out with a lot of the traditional medical and health care workforce planning. And probably one of the things that we could do from the centre is simply to encourage more people to go into that field.
I think it's all fair comment. And I'm going to open this up to the audience now for questions. Just before you do, could you please stand up, say who you are and what area you're coming from when you're speaking. So if you could stand up, please. Have we got the roving mics, please? There's a gentleman here. So please show your hands if you wish to speak.
Hello, thanks. I'm Albert Benjamin of the GP. First of all, thanks to the politicians for your talk. I quite enjoyed it. I'm a great defender of politicians, actually. I've heard there's no one from you.
Very much.
Here. But anyway, the question I want to ask, we both mentioned oneness, and I do remember asking Alan Milton way back, it was a question around this point in car. Now, you see, I slightly suspicious about this patient empowering thing. Not because it sounds a good thing, but you see, I don't think self-care is held just on, if you like, collaborative conversations. And I think to make it happen to a large extent, you have to introduce things like indicative invoicing or co-payments. And I am a strong believer in that because I think that's a way of incentivizing self-care. My fear is that the fear of electoral opprobrium stops politicians.
Could I ask if you could keep, maybe if we could have a couple of questions that you could bring together, and in your replies, could you keep them as brief as you could, so we can get more in? I'll take this gentleman here, if you got the microphone, please. Then here for John. So let's just leave it at that for now, and then we'll go, okay? So.
Thank you. Simon Poole, a GP with the BMA today. When Jeremy Hunt became the Secretary of State, first he brought a group of stakeholders together and said, I have 5 priorities, and I want you to help me try to deliver these. And one of the priorities was dementia, one was mental health, one was delivering decreased mortality. And he specifically said that I am likely to be the Secretary of State for the average incumbency of 2.5 years. So we went off to a little room to talk about how we could decrease mortality in 2.5 years. And everybody in the room's response was, look, this is just undeliverable. We have to look in the longer term. We absolutely have to look at patient engagement and public health over 5, 10, even 20 years. The number of obese patients increases over 10 years. The number of diabetics has doubled in my time as a GP. So my question is there an appetite among politicians for cross-party engagement within political circles to actually plan for 5-year, 10-year and longer periods for public health? CCGs are constrained by annual budgets they have to meet. Politicians are perhaps constrained by their average periods in office. Is there an appetite to actually have longer-term plans for public health over 10, 20 years?
Okay, I'm going to take one more question because I don't want to give you too many questions to have to answer. But there was somebody at the back. It was a Jean who was at the back. Okay.
Jean Harrismith, West Midlands Fire Service. I'm also a hospital governor. My background is clinical. We have this shared language, which I congratulate Lord Hunt on not using, where we talk about patients and we talk about healthcare. And the work that West Midlands Fire Service is doing in terms of prevention, reducing ill health, getting people empowered, providing self-care is enormous. And all governments and all healthcare providers, those that talk about patients, are missing. You cannot continue providing a health system where you just keep throwing money at it and rewarding GPs, hospitals, everyone. The whole system is based on reward. What we do in the fire service is we look at the cause of the causes. And instead of thinking about treating and being reactive, we're actually being proactive in preventing fires and arson. And by doing that, we work with young people who are in the criminal justice scheme, elderly people who cannot go upstairs to use their toilet or their bathroom, mental ill health. I won't go on, but if you'd like to hear more about what we do, on the 18th of November, we've got a conference in Birmingham where we can tell you all about it, and you're all invited, so Michael Marmot is coming. But I want to put it to the speakers to say, what are you going to do about stopping this narrow vision of healthcare, which is all NHS and poorly sick patients, and start thinking about the rotten lives that so many people have, that nobody's helping, because people go into their homes for 10 minutes. The fire service go in, West Midlands Fire Service, go in, we've got vulnerable people officers, and they will do it for a year, 2 years, however long it takes, to get those people back into good health. It's no good throwing money at poor health. You've got to start thinking about real prevention, not this silly public health word of prevention. And public health does a great job, I don't mean it in that way. But what are you going to do about looking at it from a different dimension?
Thank you, Jean. Thank you, Jean. And you even managed to get an advert in for the conference, which is in 2 weeks' time in Coventry. I recommend that you go. 3 very, very good questions. I'll start off first of all, we'll change the order now. Lord Tom, would you like to respond?
Yeah, just on the West Midlands Fire Service, I do very much pay tribute to the work that you've done, and indeed your former Chief Fire Officer has just been appointed to the Council of the Royal Society for Public Health, and that's kind of first and is an indication of the fantastic job It's My Own Fire Service has done to realise that firefighters have a much wider role than one would traditionally think, and they've got a fantastic headquarters which has got a great atrium where they allow community groups to come in and have conferences, and it's a fantastic example. But of course the challenge was about getting serious on public health, and I do so agree. I think too often public health has been built around these ghastly needs assessments that are produced, voluminous documents that never translate themselves into any action. And I think you're absolutely right. I think it'd be so much better if health and wellbeing boards decided there are 3, 4 or 5 things they were really going to go for, and actually proved that a concerted, intersectoral, to use that jargon word, embracing so many different stakeholders actually would begin to really get a grip. And of course the figures, the gap, would suggest that the current approach to health is simply not going to work in the future. We clearly have to change. On the issue of the need for long-term stability, I do agree with you. It doesn't always fit with the short-term nature of politics, and I think we can all see that and some of the downsides of it. I think the NHS England 5-year forward plan, if you call it that, was a really interesting approach, because I think many people would agree with its general thrust. There will always be political argument. There will always be, one of the frustrations at the moment for politicians is ministers kind of do not seem to have the same levers they used to have. And that is a frustration. There will always be accountability issues. But I do agree with you that in terms of long-term planning and funding, we have got to have a much longer-term vision. Just on, I'm not sure I got the point about GPs. Was it an indicative budget that you wanted to see? Did I?
No,
I think it's co-payment.
Co-payment.
Indicative invoicing. You see, because
indicative.
at present, people are not aware, by and large, of the cost of it. I wrote a prescription the other day for 2 months, which cost over £700. Now, I think it's great the patient needed it, but I think across the board, people are not aware here as GPs, but people, and this is an extension of democracy, they ought to know.
No, fair point. I'd always worry if that were then turned as a sort of prototype of a system that then led to charges, which I would be opposed to. But I do agree that as part of the education agenda raising, allowing, encouraging people to know more about costs, I think would be very helpful.
So, yes, please.
Well, Lord Hunt has said much of what I would like to have said. It's not very sort of fashionable to sit on a platform like this and say what I actually believe, which is that there is more that unites the political parties in the field of public health than divides us. I agree with Lord Hunt that the 5-year forward view is a very useful and indeed persuasive document. Bear in mind that although it was published under the NHS England banner, it was the product of a lot of joint work with Public Health England, with Health Education England, with the regulators and so on. So it is, as it were, a national forward view rather than just an NHS England focused forward view. And it very, very importantly, I think one needs to say it wasn't a document produced by government, and my belief is that it's thereby all the more credible. Of course, there is little that can be done in a couple of years to reduce mortality, but there's a lot that can be done in those 2 years to define what we need to do to reduce mortality, and that work is ongoing. It's ongoing in NHS England, in Public Health England, and I'm sure will continue after the election. Absolutely, the Westminster Fire Service point made absolutely right. And I do congratulate what that fire service is doing, and it brings home to me what I've come to see increasingly in my travels around the NHS, that actually we should look to people other than healthcare professionals to drive this agenda forward. I was visiting a GP practice in North London on Friday, in Burnt Oak actually, which is engaging in some really very exciting work with local voluntary groups. And these voluntary groups their function in this context is to reach out to people in the community who are sometimes lost to the system, but sometimes are a great burden to the NHS, and actually looking to meet their needs in ways other than healthcare. The unemployed, ethnic minority communities who don't engage with the NHS very well, and so on and so forth, giving them signposting, information, confidence to go forward. And I was really, really excited by this. The NHS, jointly with the voluntary sector, tackling some important social problems. So money is not the whole answer. It is part of the answer, I have to say, because we cannot ignore the money. Which brings me to the first question. I think I certainly agree with Philip that we need to do more to make patients understand broadly that they what they cost to the system. I wouldn't be in favour of charging. I quite agree with Philip. So anything that moves in that direction, I'd be opposed to. But for example, there's been some quite interesting work going on recently in reminding patients to keep their GP appointment. And the way that the reminder is phrased, and this is done by texting, and increasingly, it's quite a good way of making sure people keep their appointments. But the most effective text that has been tried out is one that says, do remember your GP appointment is at such and such a time, so the cost of missing an appointment is £160 or whatever it is. And it's that message that has gained the most traction with patients, very interestingly. I think we can motivate patients better with that sort of thing, but we've got to be careful. Some research was done recently which showed that if you tell people exactly how much their treatment costs, there is a certain sort of patient out there who will say, I don't want to be a burden to the system. I'm not going to cost the taxpayer this, and therefore they don't seek the help that they need. So the last thing we want to do is to deter patients from going to the doctor when they actually need to.
I must say, just to follow, just to say, I mean,
Briefly,
I don't think,
please,
Freddie, you were there in the House of Lords on Friday, but we debated the assisted dying bill. And it's interesting, one of the key debating points is about undue pressure on individuals because of how they feel they're a burden either to society or to their families. And I think you've got to be very careful not to put people under undue pressure.
I'd love to return to that because I was at a conference very recently in Poland, an international conference, and speaker after speaker said the problem is, I knew what they were trying to say, but they said the problem is that there are too many old people in society.
Yes.
And I know what they were trying to say.
Exactly.
But when it was my turn to speak, I did say, try saying that this way. Try saying that the problem is there are too many black people in society. Try saying the problem is there are too many Jewish people in society. Try saying that and see how that sounds. Why on earth can you get away with saying that there are too many old people in society? What an incredible statement that actually is. The problem actually is, it's not that there's too many old people in society. There are insufficient number of politicians who value older people sufficiently to actually invest in their health and invest in actually in the workplace. That's what the problem is. Can we have the next and last speaker, please, for a question? I'm sorry we've run out of time. Actually, we'll ask John as well one more time. Go on.
I'm Marion Steiner. I'm a GP in the private area of Bristol, and I'm the self-care lead for Bristol CCG. And we've developed a self-care strategy that takes into account a lot of the factors that we've been talking about. So the strategy encompasses community and primary care and secondary care. But just to talk about what happens in the consultation with the GP, what I've learned is that every patient has a capacity for self-care, and we need to find out what that capacity is, and we need to build on that capacity. But that is not a quick fix. And the way that general practice has gone with the development of cough indicators and the tick box sort of mentality around consultations is completely in conflict with working carefully in every consultation to engage the patient. So my plea to politicians would be to be thinking about those precious 10 minutes. Could they be extended to precious 15 minutes? Would that be much more realistic to invest in time? Because clinicians in the NHS, all of us would like more time. And there are elements in the system which bring out the best in clinicians, and there are elements which reduce that capacity, and that's what the Francis report revealed. And time is one of the biggest elements.
I'm actually going to leave it with that last question with you both. Earl, if you like to just do Earl Howe, if you'd like to answer that.
We're very aware from what we're told from all around the country by GPs that time is one of their most precious assets. And I think that first thing to say is it was with that in mind that the GP contract was varied this year to take out more than a third of the QOF indicators, which GPs told us were getting in the way of the conversations they needed to have and were taking up unnecessary time. So that was a start, and I hope an indication of good faith by us, and it went down well with GPs. We maybe need to go further than that. We've got to be a little bit careful because the BMA are very keen on maintaining the QOF, which has proved its worth over the years, but it needs to keep being refreshed, I think. But surely, and you're right to say nothing can happen in a hurry, and that different patients have different capacities to self-care. I totally accept that. But surely over time, the kinds of conversations that we've been talking about between patient and GP need to include that sense that actually if you've got a minor ailment, your first port of call should be the pharmacy. Actually, if you're feeling unwell and don't know what to do on a Saturday, ring 111 and you will be pointed in the right direction. That kind of thing, I think, will gradually change behaviour in a way that should enable the burden on GPs to be eased in the way that we all want to see. So I think there is, if I may say, some onus on GPs to ensure that their patients are informed in this way, and also directed to the right person in the practice. It isn't always necessary to see the GP. You can go and see the nurse or the physio or whoever it is, and patients have got to be educated in that way as well.
I do think that, I think it's okay to have incentive payments towards practices or GPs. I think that it's one way to encourage the development of programs in the way you want to do it. I agree with you about the ticks box approach, and I do think, for instance, this sort of proposed payment for identification of dementia, I don't think that is the right way to go, and I think there is this direct connection, if you like, between money in the pocket and diagnosis by a GP is something to be avoided. But it'd be very interesting to learn from your experience about both the pitfalls and the, if you like, the achievements, and see whether we can start to see some development of more integral practices, to see whether we can build on that in the future. Overall, and I agree with Freddie about the kind of the signposting for the public. It's not strong enough yet. I don't think for individuals there is a strong enough signpost towards a community pharmacy or to 111. And you go to, I've got brilliant experience actually of GP primary care all my life, but actually very rarely do you see really major signposting coming from practices about how you ought to use the system. And I wonder if there is something there that we could work on in the future.
That's something I think we could take for the future. Can I just have a show of hands, please, with your red and green card? With a green card, would you seriously consider voting for a party which did have self-care in its manifesto? Could you put a show of hands, please? Well, there's a few votes there. If only you could say yes. If only you could say yes. So next year, whoever forms the government, we will invite that member of the government to come back to where you are sitting now, and we will ask you, did you include self-care in your manifesto, and how are you going to act on it? But thank you very much indeed for taking part in our conference today. Thank you. A big hand for this.